Hello, I'm Dr. Stephen Phelps from Memorial Health DuPont Hospital for Children in Wilmington, Delaware. Very happy to join you in practical pediatrics. We're going to talk this afternoon about missed emergency medicine cases and hopefully give you some pointers so that you won't make these same mistakes in your office practice. I will disclose that I receive royalties from Elsevier for a textbook, Pediatric Emergency Medicine Secrets, and I'm an expert witness for a few law firms as a patient. I do practice pediatric emergency medicine at DuPont Hospital, and most of the cases that I will refer to came from the emergency department, but I assure you the lessons learned will be very valuable to you in office practice as well. So why do we make mistakes? Well, certainly in the emergency department, we're very busy. I'm sure you are in your office as well. We're also very tired. We work long shifts. Again, same thing probably true in your office. I'm sure you also have many distractions, complicated patients in the emergency department. We have to make very quick decisions. Some of these are life-saving decisions. And in several cases, there's lack of teamwork. And that probably happens in your home office as well. This is what our emergency department looks like on a Friday night. So you can imagine that we're going to have a chance to make some errors. We're tired from all the long shifts that I mentioned. We're always doing two things at once. I'm sure you feel this way as well. You're pulled in many different directions in your practice. In fact, there was a study done that showed that emergency physicians are often distracted. This study followed doctors and nurses around an emergency department, and they found that the emergency attendings were interrupted 8 times in the course of an hour. And nurses were interrupted 12 times in an hour by phones, pagers, other people bothering them, check this laboratory test, talk to this person, a phone call on this line. They found that these clinicians performed between 1 and 8 activities before returning to their original task. So I think you can imagine that when you're trying to make life-saving decisions on a critical patient, the chance for error is pretty high. So which mistakes are common in emergency medicine and probably in office practice as well? Diagnostic errors are the most common. This is what pediatricians do. We make diagnoses. We also have many communication failures. We have fewer technical problems. It does happen sometimes when we do procedures, but we're not like surgeons. We're not doing procedures all day in the operating room, so we're more likely to make diagnostic errors than technical errors. So diagnostic errors, study that I was involved in when we looked at malpractice cases. The most common malpractice cases involve failure to diagnose meningitis, appendicitis, failure to manage fractures appropriately, and failure to diagnose and manage testicular torsion. A more recent study showed that cardiorespiratory problems are the most common cause of malpractice in pediatric emergency medicine, but meningitis is just not seen very much anymore, so it's dropped off the list, and fractures have dropped off the list, but failure to diagnose testicular torsion and failure to diagnose appendicitis are still very high on the list of mistakes that emergency physicians make. We also fail to manage wounds very well. There's frequently complications, often when a physician tries to take on a wound that's a little bit too complicated and should have been referred to someone else. Medication errors are still very high in pediatric practice in the emergency department and in your office as well. Myocarditis is a difficult diagnosis to make. Fortunately, it's not a very common diagnosis, but it's often missed. A study that I was involved in showed that half of the patients with myocarditis were seen by a practitioner in 2 weeks before the diagnosis was made. In about a third of the cases, they were seen twice before the diagnosis was made. So it can be a difficult diagnosis as it mimics other conditions. And dehydration, it's hard to believe that we could mismanage dehydration or not recognize a dehydrated child. But when you go back and look at the cases where this was missed, many of those children were managed over the telephone. I think it points out that the difficulty of managing children by phone. So what can we do to prevent some of these errors? Well, always act reasonably. Listen to the mother. I'm sure you know this as a pediatrician. Parents know their child better than we do. And if the family is very concerned, the mother or the father says, "Doctor, there's something wrong with my child," the child probably shouldn't be going home. If there's something that bothers you about the history or the physical exam, don't make excuses for that patient. Send the patient to the emergency department. Keep them around. Don't let them go home. We should really focus if the patient is continuing to vomit. If that child can't drink a few ounces of fluid in our emergency department, at least 4 ounces, I wouldn't send the patient home. I've learned that the hard way, and it can't be just a few sips. They have to be able to take a few ounces. Same thing with lethargy. Don't make excuses. Well, it's the middle of the night. Of course, the child's tired. The child was up all night. If you can't convince yourself that at one point in time you saw this baby looking very well, you shouldn't send the patient home. Certainly, we have to arrange for appropriate follow-up. Communication failures, I mentioned, these happen often in the office as well as the emergency department. Certainly, we need to be very careful and communicate well with our patients and families, but also we have to make sure we have good communication with our staff, our nursing staff, and others in the office and the ED. And certainly, if you call a consultant, we want to make sure we communicate well with them. Failure to communicate is a major cause of sentinel events, according to the Joint Commission. So the most serious errors that are made often involve a communication error. And we have to communicate well with our nurses. They're very important. They're watching the patient, probably spending more time with the patient than we are as physicians. So we do have to relate well to them and make sure that we're communicating well. Our radiologists are very important to communicate well with them. Hopefully there's a system in place at your hospital if the radiologists pick up an incidental finding, or if they change their reading down the road, that they get back to you with the final reading to make sure that you understand what they found on those radiographs. Certainly we have to communicate well with our patients. I'm sure everybody knows that, and I'm sure you do that very well, but the fact is we do fail in this every once in a while. This interesting study out of Michigan, they interviewed families after leaving the emergency department, and they asked them about 4 different domains. Do you understand your diagnosis? Do you understand what they did for you in the emergency department? Do you understand what you're supposed to do at home, your post-emergency department care? And do you understand when you should return to the emergency department or see another physician? And they found that in 78% of the cases, the patients couldn't list one of these domains. They didn't understand one of these domains. And in half the cases, they were deficient in 2 of these domains. So I think it indicates that maybe we don't communicate as well as we thought when patients leave the emergency department. So upon discharge from the ED, that's certainly when we have to be very clear with our families. We need to make sure they understand what to look for at home, when to return to the emergency department, and when to go back to see the primary care pediatrician. I think we're all very careful in the ED to go over this with families and make sure they understand when it's time, what are worrisome findings, so when it's time to come back. This study followed doctors and nurses around as they were giving discharge instructions, and they audio taped more than 800 of these, and they found that the verbal instructions to families and patients were often incomplete, and they did not ask, and in many cases they didn't give the patient a chance to ask questions or to confirm understanding. In pediatrics, we should keep in mind that when you tell a family to go see your primary care doctor after leaving the emergency department, it only happens about 60% of the time. Now maybe the patient gets better, but maybe the family didn't understand the instructions, and they don't always follow up as we think they're going to follow up. So it's recommended that we verify comprehension, have the family paraphrase that teach-back method that asks the family, do you understand the instructions, and let's go over what I instructed you to do. There are others that recommend using pictures and diagrams to go over discharge instructions with family. So technical problems, I said, is not very common in pediatric emergency medicine. It does happen. Certainly it happens less in office practice, but we do have to be careful if we're trying to do a complicated procedure. We have to think twice till we refer this patient to a specialist rather than take on the procedure ourselves. And failing to monitor the patient, this is a major cause of problems in the emergency department and in the office as well. All right, let's go over some cases. And we're going to focus on diagnostic errors because I think that is the most common and the most interesting ones for pediatricians to review. And we'll go over the first case is a 15-year-old boy who comes to us with chest pain for 1 week. And the story is he was playing football a week ago. He got hit over the right ribs. A few days later, he had neck pain and stiffness. And now he complains of chest pain. And his pain is worse with walking. It's an achy, stabbing pain. It's worse with exertion, and he has trouble even walking up the steps. He has mild dizziness with standing. He He can't climb the stairs. He's unable to run. He's short of breath at night, and he has headache every once in a while. He has no cough or cold symptoms, no head trauma, no fever, no jaw pain, very little past medical history. These are his vital signs. His temperature is 38.3. Pulse is 78, but it jumps up to 106 when he's standing. His respiration is 24. His blood pressure is slightly elevated. He's alert. He's a talkative, obese male. His neck has some mild tenderness and some limited range of motion. His torso is tender over the sternum. No CVA tenderness, no rib tenderness. His lungs are clear. His heart sounds are normal. His abdomen is benign. The rest of his exam is unremarkable. I did an EKG. It shows a lot of non-specific findings, some left axis deviation, some ST elevation, borderline prolonged QT. All of these were borderline. They did get a chest x-ray, and the x-ray reading shows top normal heart size is what they were calling it, and clear lungs. So I can tell you what they did. They gave him some IV fluids. They thought maybe he was dehydrated. Maybe that's why his heart rate jumped up when he stood up. But after IV fluids, the vital signs were unchanged. They called the cardiologist because of the chest pain. The cardiologist over the phone said, I think this is just musculoskeletal pain, nothing to do for this patient except some analgesics. It sounds like a chest ball injury from playing football. Give him some ibuprofen and tell him to come back if his pain gets worse, and follow up with his pediatrician because his blood pressure is a little bit elevated. And I can tell you what happened. This child, unfortunately, he did come back 8 hours later to another hospital, and he had expired at that time, and the cause of death was myocarditis. So looking back, this is a pretty classic case of myocarditis. The patient's had chest pain for a week, and the pain started to get worse as time goes on. Now he develops respiratory distress, pain with exertion. This should be a key that this chest pain is serious and may be related to cardiac etiology. And many patients with myocarditis will have a resting tachycardia and orthostatic changes, as our patient had. Eventually, they're going to develop muffled heart sounds and a gallop rhythm as things progress. Our patient, when he was seen initially, did not have those findings. And eventually, they will go into dyspnea, shock, arrhythmia, and death. So the teaching points here, if you have a patient with chest pain and fever, you should take that seriously. Most kids with chest pain, as you probably know, have a good outcome. They have a benign diagnosis. But chest pain with fever is a different category. Many of those patients either have pneumonia, or if it's not pneumonia, you should be thinking about a cardiac problem, such as myocarditis or pericarditis or endocarditis. Chest pain with exertion, we should take that seriously. Child has difficulty running up the steps with chest pain and shortness of breath. There's a good chance that there's a cardiac etiology there. So get a chest x-ray and EKG in those settings, and if you think you need a cardiologist, don't let them talk you out of it. If you need a consultant, tell them we'd like you to come and examine the patient rather than manage this one by phone. And think about the vital signs. In this case, I think the physicians were misled. But if the vital signs don't improve after giving fluids, maybe it's not dehydration. Maybe there is a cardiac etiology, cardiac insufficiency. All right, here's another case. A 13-year-old boy presents with abdominal pain. He has no allergies. He's taking only acetaminophen, no past medical history. He's had this right lower quadrant pain since the morning. This is what our triage nurse finds out. He's had nausea, vomiting. He walks with obvious pain. He has had no stool for a few days. He does have fever. The triage nurse notes he's awake. He's guarding his abdomen, but he's able to jump off the stretcher without difficulty. It didn't seem like there was any peritoneal finding. The emergency medicine doctor goes in a little bit later. Gets pretty much the same story. The pain began yesterday in the right lower quadrant. He has nausea and vomiting. Pain is better with movement, as the triage nurse found. The doctor finds he had some pain when he voids in the past. Not currently, but in the past he's had difficulty. He hasn't noticed any blood in his urine at this time. These are his vital signs. He's febrile. The rest of his vital signs are pretty unremarkable. His AT&T exam is benign. Heart and lungs are normal. His abdomen does show some tenderness in the right side and the left lower quadrant. He's got some mild guarding. No rebound, no mass. They did a rectal exam. We don't do that too often anymore, but the rectal exam was normal. Got an x-ray. You don't get an x-ray in every patient with abdominal pain, but in this case they got an x-ray and it showed a small calcified mass, maybe an appendicolith, maybe a kidney stone. This is what the emergency medicine doctor thought, and the radiologist read it as well like that. They did observe the patient, which is a good thing, and found his pain improved, but he didn't have peritoneal signs. This is his CBC, his white count, pretty unremarkable. Bands may be slightly elevated. His urinalysis is normal. Negative for protein, blood, nitrites, some trace ketones. The diagnosis was made as renal lithiasis. The doctor instructed him to repeat the urinalysis, give him some fluids and acetaminophen. He was said to be taking oral fluids well. We don't know how much he took. Pain-free, but still had abdominal tenderness in the diagnosis. Final diagnosis was renal colic or acute gastroenteritis. And the patient was discharged to home, told to take ibuprofen, drain his urine, look for kidney stones, and drink lots of fluids. This patient, probably all of you are thinking, what in the world was that doctor thinking when they sent him home? This is not renal lithiasis. This is appendicitis. And I think this points out that it can sometimes be a difficult diagnosis. Maybe not in this case, but appendicitis fools us all the time. It's certainly a good idea to review the x-rays. I think they were misled by the x-ray in this case. I think the doctor saw what he wanted to see. He had made his diagnosis of kidney stone and immediately went to the x-ray and said, see, there it is, there's the kidney stone. But consider getting an ultrasound or a CT scan. In my hospital now we get an MRI. That's our standard test if we're concerned about appendicitis, if we're not sure by our clinical examination. We try to avoid the radiation of the CT scan. Certainly a good idea to re-examine the patient. They did that here. Certainly important to document carefully. And I would say don't wait for the classic case to be found. It's just not going to happen that often with appendicitis. If you have a patient with a classic history and an impressive exam, it doesn't matter what the laboratory tests are, you should call the surgeon and admit the patient to the hospital. Just 2 of these 3 should be enough for you to be worried about appendicitis. It's rare that the patient has a completely classic story. I think what happened in this case, this was a cognitive error that the doctor made. Again, there may have been a lot going on in the emergency department. Things happen quickly. There's many other sick patients to take care of. Maybe this doctor was distracted by that and didn't give full thought to this patient with abdominal pain. But it seems to me the doctor, again, had premature closure. And the doctor, as soon as he heard this patient's had trouble voiding in the past, with pain with urination in the past, the doctor said, oh, it must be a kidney stone. And then looked at the x-ray and said, see, there it is, there's the kidney stone. And the doctor ignored all the other findings. The fact that this patient had no blood in his urine, the fact that the patient had fever, these should have been red flags that this is not kidney stone. This is more likely to be a problem like acute appendicitis. All right, here's another case. A 16-year-old girl comes to the emergency department with difficulty breathing. As it turns out, she was driving with her friends. It was a Friday night. She was out having a good time with her friends, and suddenly she became ill and convinced her friends to drive her to the emergency department. So she said she's had trouble breathing for 45 minutes. She has a past history of asthma. The triage nurse found that she's alert but dyspneic. She has numbness of her hands and feet. These are her vital signs. She's febrile. She's a little tachycardic and tachypneic, mildly hypertensive. The doctor comes in a little bit later and finds that she has some shoulder pain, left upper quadrant pain. Again, the story was told that the symptoms began while she was out driving with her friends. She had this numbness and tingling of her fingers. The breathing problem that she had, that's already gone. She's breathing fine now, but now everything hurts. Her arms hurt, her back hurts, her legs hurt. She's having pain everywhere. The doctor determines that she's seen a psychologist in the past for stress, and maybe that influenced the doctor's decisions. The patient appears anxious and upset, but her exam is otherwise unremarkable. Her abdomen is soft, a little bit of left upper quadrant tenderness, but the extremities that she's complaining about, she says she has pain in all of her extremities. They're completely normal with 4 range of motion and normal pulses. The parents come to the hospital about an hour later, and the patient says, let's just get out of here. I feel fine, I want to go home. The reality is she was just frustrated. She and the family felt that the emergency department wasn't doing enough for them. The doctor's writing in his note that it's a histrionic patient. And again, they re-examined the patient. Her joints were normal. There was no swelling. Her abdomen was fine. They had gotten a chest x-ray that was normal. and they diagnosed viral syndrome and told her to go home and have rechecked by her primary doctor in 3 or 4 days. So I can tell you what happened to her. She did go home. The primary care doctor called the emergency department a little bit later and said the family is very unhappy with the care that they got there, but I'll see her in my office tomorrow morning. Unfortunately, in the morning, she couldn't stand up. 911 was called. She was found to be critically ill. She had a purpuric rash and was noted to have meningococcemia, and unfortunately lost both of her legs below the knee. So we can think back on this case. Would we have done something differently? Would we have done laboratory tests? I don't know. I don't know that a CBC is indicated for every teenager with a fever. We don't always do that. Was the diagnosis reasonable? There, I think we could argue. They made a diagnosis of viral syndrome, but there really was no syndrome. The patient had no cough or cold. She had no vomiting or diarrhea. I think this points to the fact that we shouldn't just label things as a virus if we're not really sure what's going on. Was the discharge appropriate? I would say no. This patient couldn't walk out of the emergency department, had to go out in a wheelchair. And any patient who's in too much pain to walk out of the hospital probably shouldn't be going home, regardless of the diagnosis. And was the outcome altered? Well, I would assume this patient with severe overwhelming meningococcemia was going to have a bad outcome no matter what. But the legal outcome would have been different had the patient been admitted to the hospital and treated. So meningococcemia can be difficult. If you see that purpuric rash, petechial rash, I think with fever, all of us are going to make the diagnosis. But they don't always present with a rash, a petechial rash. Some of them do present with bone pain, with back pain. I think the point here is don't call it the flu, that there's no other symptoms of the flu. It's not flu season. And don't discharge a patient who's in severe pain unless you're sure of why they can't walk. If they can't walk out of the emergency department, you don't let them go home. All right, here's another case. A 5-year-old girl comes to the emergency department with persistent vomiting. She was seen by her primary care doctor. This is the note from her primary care doctor. The primary doctor says, I'm sending her to the emergency department because she's been vomiting. She has a positive strep test in my office, but I'm really sending her because of this foul-smelling material that she vomited. It smells like fecal material to me. And we got an x-ray that shows that she's constipated. So in triage, they find that she has been vomiting off and on actually for a few months, but she's vomited 8 or 9 times today. She's alert, moist mucous membranes. These are her vital signs. They're pretty unremarkable. The emergency physician notes what the primary doctor had found, that she has this greenish-brown emesis. She's had crampy abdominal pain, no blood in her stool, and an x-ray that shows constipation. And she's well-nourished, she's well-hydrated, she does have an injected throat. The doctor knows about her strep throat. Her abdomen is not tender, normal bowel sounds. They did a rectal exam again, and hard stool was found. There's treatment in the emergency department. They gave her some enemas, they gave her some fluids. She was discharged to home. Unfortunately, this patient came back the next day with seizures. And at that time, someone got a head CT and found that she had a brain tumor, and she eventually went on to brain death. So a very sad case, and I think this case tells us that we need to consider the central nervous system when we have a patient with vomiting. I don't know if a neuroexam was even performed in this case. There was nothing documented in the chart about a neurologic exam, but this was a clear error that the central nervous system was not considered in the patient who came in vomiting. Was the outcome affected? Well, again, this patient with a brain tumor severe enough to cause death the following day, probably there wasn't all that much to do for this patient, but the legal outcome would have been different had the patient been admitted to the hospital. So the teaching points here is, I'm sure you all already know that vomiting is not always a GI problem. That's our first line of thinking, that this must be a viral infection, gastroenteritis, but if there's no diarrhea associated with it, you should give it some second thought. Vomiting and diarrhea together usually is gastroenteritis, but if there's vomiting alone, we have to consider other things like pneumonia, meningitis. We've had patients with DKA who've been discharged to home with a diagnosis of a GI bug when in fact they have diabetic ketoacidosis. So you certainly have to consider central nervous system pathology like a brain tumor. All right, here's another one. This is a young girl who's obviously been mauled by a dog. I think the injury here is obvious, and I think it's obvious that we're not going to fix this patient ourselves. We're going to need a plastic surgeon to help us. And I can tell you this patient with a dog bite, plastic surgery was called, and they sutured those facial wounds. But the child came back to the emergency department a few days later with vomiting. And at this point, someone got a head CT and found that she had a brain abscess. And what happened here is apparently the dog's tooth not only mauled the child's face, but the other end of the jaw went into the child's skull. And the tooth fractured the child's skull, and that allowed bacteria to get in, and she developed a brain abscess. The child did well, fortunately, but clearly this scalp wound, the skull fracture, was missed at the first emergency department visit. So the teaching points here, I think we can all learn a very important lesson here. Don't focus on the obvious injury. No one's going to miss that facial laceration. So I would recommend examine the rest of the child first. Leave the face alone and examine every other part of the body. Look for other wounds. And especially what we learned from this case is that there's a big dog and a little child, there's a good chance that that dog caused a second injury to that patient. So look elsewhere for the injury. Look for this, examine the skull under her beautiful hair to see if there was penetration of the skull. So always examine the rest of the child. Avoid the obvious injury. When I have a child that comes in with an arm fracture, I leave that arm alone, look everywhere else. I remind the mother that I know where the injury is. I'm not ignoring the injury, but I want to make sure there's no other injury before we focus on the obvious one. All right, 2-year-old boy comes to you with something in his nose. In this case, the physician assistant tried to remove a foreign body from the nose and was unable to do so. Called the emergency doctor. He tried a few times. The child was agitated. The doctor just gave up and said, why don't you go to your pediatrician or see an ENT doctor in another day or two. The patient did go to see ENT. Fortunately, the next day, they got this x-ray, and I think you can see from this rim here, this double rim, that this is a button battery in the nose. So that is a problem. This patient developed perforation of the nasal septum down the road and may end up with permanent deformity. So a button battery left in the nose for a whole day, that's a problem. It really needs to come out immediately. This is what the patient looks like, or might look like. It's not the same patient, but this is what the patient might look like. The mother said after just a few hours, she thinks the patient might have put a battery in his nose just a few hours ago at most, and you already see a lot of redness and swelling and pain, some nasal bleeding here. This patient had a button battery in the nose. So these can cause burns and necrosis very quickly, within a few hours. And I think the point here is that if you're not sure what's in the nose, get an x-ray to make sure you know what you're dealing with. And if it's a button battery, you can't send the patient home to be evaluated the next day. It has to come out right away. But if you can look in the nose and see for sure it's a little plastic bead, or the family identifies it as such, you probably could refer that patient for the next day. But you want to be sure that this is not a button battery before you send the patient home. All right, here's another patient. 13-year-old boy comes to us after climbing a fence. He got his foot caught in the fence, and his knee struck his groin. A few days later, he had scrotal swelling and pain, and comes to the emergency department complaining of tenderness and pain of his left hemi-scrotum. And the emergency doctor heard about the trauma and recommended ice and followed up with urology. Unfortunately, a couple of days later, the patient did see the urologist and was diagnosed with testicular torsion. So I think this is a pretty classic case. It happens very often that people misdiagnose testicular torsion, especially if there's minor trauma to the groin. In about 10% of the cases, there is minor trauma. 10% of torsion cases, there's minor trauma that confuses the diagnosis. All of the men in the audience know this is an area that's commonly injured, and that doesn't mean you can't have testicular torsion. Now, that's just a red herring, that minor trauma. And also, we should remember that many of these patients present with abdominal pain. They don't even tell you about their scrotum. Whether they have scrotal pain or not, I'm not 100% sure. Some kids just don't want to talk about their scrotum. But I think it's pretty clear that many boys come to us with abdominal pain, and yet they have testicular torsion. So the bottom line is that any boy with abdominal pain, you have to examine the genitalia to look for testicular torsion. So rapid diagnosis is essential. After about 8 hours, that testicle is going to become necrotic. So we really need to get the patient to a urologist and to the operating room within 8 hours. So don't delay in doing that. If you have any suspicion at all, call the urologist, give them a heads up as you're sending the patient off for a diagnostic evaluation. And an ultrasound is what we would normally do now, an ultrasound of the scrotum. But even that is not always diagnostic. If the urologists are really worried, if you're really worried about that scrotum, they may need to go to the operating room, even with a normal ultrasound showing blood flow. So there's lots of ways to misdiagnose testicular torsion. I think one thing also, many people don't consider this in their infant, but keep in mind that infants also get testicular torsion. It's a bimodal peak. So here's another patient, a 15-year-old girl comes to the hospital with a syncopal episode. She was playing baseball, and she fell to the ground. She had some brief twitching movements when she fell to the ground. The emergency department did some blood tests. I'm not quite sure what they did or why they did blood tests, but they diagnosed a heat-related illness. It was a hot day, playing baseball. Maybe she was a little dehydrated. The patient had a scalp laceration when she fell. They sutured those wounds, and they discharged her home to follow up with her primary care doctor. A year later, the patient had another syncopal episode. This happened while she was in the laundry room, a hot laundry room. She became briefly unresponsive, but recovered quickly. Went back to an emergency department. Again, they did some blood studies, not quite sure why, and they diagnosed vasovagal syncope, probably from standing in a hot laundry room, and they discharged her to home. Unfortunately, a year later, again while playing baseball, she collapsed, and this time an EKG was obtained and it showed long QT syndrome. The patient had a cardiac arrest. She was resuscitated, but had a very poor outcome. I think this case really teaches us some important points. First of all, you can have seizure-like activity when you have a syncopal episode. A patient with an arrhythmia will have a brief episode of hypoxia. They're going to fall to the ground and have seizure-like activity. It's often misdiagnosed as a seizure, except they don't have a post-ictal state. They wake up very quickly and they return to normal function very quickly from an arrhythmia. But I think if there's an injury, when a patient has a syncopal episode and an injury that results, you should be very concerned about a cardiac problem. Most patients with a vasovagal episode of syncope, they lower themselves slowly to the floor. They rarely get injured. But in this patient who had a scalp laceration that needed sutures to repair, you should be very concerned about a cardiac etiology in that situation and consider long QT syndrome, especially if there's syncope related to exercise. The patient's playing baseball and falls to the ground. Before you think about heat-related illness, you should think about a cardiac etiology like long QT syndrome. All right, 15-year-old boy. This boy has trisomy 21, so may have some communication issues. Can't tell us exactly how much pain he's in or where the pain is, but he's limping, and he's indicating that his left knee hurts. X-rays were obtained of his knee, and they made a diagnosis of chondromalacia patella. They didn't find much on the X-rays, no fracture. The patient came back 2 months later, though. His limp is now worse, and now he was diagnosed with slip capital femoral epiphysis, or SCFE. So here's what his X-ray looks like now. They got X-rays of the hips, which shows that the SCFE, the slip capital femoral epiphysis, we refer to this as the ice cream slipping off the cone. This is the classic finding. This one doesn't look so bad on this side, but clearly the ice cream is slipping off the cone here. And here's another angle where you can clearly see the ice cream slipping. This is a classic case of slip capital femoral epiphysis. And this is often more likely to happen in adolescent males. It occurs spontaneously after minor trauma. So the patient may have a minor limp for a little while and then falls out of bed, and all of a sudden now the patient is completely incapacitated. It's a pretty classic story for SCFE. They may have knee pain. I think that was the misleading factor here. In this patient complaining about pain of the distal thigh or knee, don't be misled by that. If the patient has knee pain, you clearly have to examine the patient's hip to look for slip capital femoral epiphysis. You want to make sure that they can rotate and flex their hips. If not, you want to get an X-ray of the hips. I think here the problem was they got X-rays, but they X-rayed the wrong joint. They X-rayed the patient's knee rather than his hips initially. This is very important because the treatment for SCFE is immediate bed rest. The slip is going to get much worse and can result in permanent damage if the patient is allowed to continue to walk with the SCFE. You want to get them off their feet immediately and consult ortho as soon as possible. All right, a 4-year-old girl comes to the emergency department. The family brings her in because of blood noted in her underwear. And she's otherwise well. She has no known injury. She was in the care of a babysitter. The parents are concerned that maybe there was some sexual abuse Why does this 4-year-old present with blood in her underwear? Here's our physical exam. And if you were to diagnose, if you were to be concerned about sexual abuse, I could understand that. But I hope you would recognize that this donut shape here, first of all, it's not her vagina. Her vagina is normal. There's no blood from the vagina. This is her urethra. This donut-shaped mass is a urethral prolapse that often presents with bleeding into the diaper. So it's misinterpreted as vaginal bleeding. You often have dysuria as well, but this is urethral prolapse. It's more common in African American girls for some reason. It's usually young girls, and it can present with straining to cough or straining to stool, and it just pops out. And the treatment here is really to just observe the patient, warm compresses and sitz baths. They often don't even need a referral to a specialist. Sitz baths, warm compresses, and many people will treat it by application of estrogen cream to the area. Now this patient comes a 6-month-old with bleeding from the mouth. And here's our patient. This patient was also in the care of a babysitter, so that should raise some red flags. Whenever we hear that, we should have child abuse on our radar at least. There was no known injury here. The patient is not willing to feed now because there seems to be irritable, seems to be some pain of the mouth. The child has no fever. The exam is otherwise unremarkable. So in this case, you should be thinking about child abuse. When you have a frenulum tear like that, it's very often due to bottle jamming. The patient may have had a bottle jammed into the mouth for feeding. This frenulum tear, is often associated with child abuse. So it's like a frustrated caregiver that jams the bottle in. If it's an older child and they report that the child fell onto the face, well, then we could believe that injury. But a young child who's not ambulatory, that story would not be plausible. You have to be very concerned that this happened from bottle jamming and be worried about child abuse in that situation and refer for child abuse. So unfortunately, missed child abuse often results in a fatal injury, so we don't want to make a mistake like that. All right, here's a 7-day-old who comes to us with a rash on the scalp. It's a very young baby with this rash. He has no fever, slightly decreased feeding, but the baby's otherwise doing well. The pregnancy and labor are uncomplicated. The mother does report that there was a scalp monitor placed on the baby at the time of delivery, and unfortunately that's misleading. Here's what the rash looks like, what the lesions look like on the scalp, and it was misinterpreted as a scalp monitor wound. But this turned out to be herpes simplex. I'm sure many of you were onto that from the beginning. Whenever we see a rash on the scalp, especially a vesicular-looking rash, we should be thinking about herpes. In this case, the mother was asymptomatic, but remember, in half the cases, the mother is asymptomatic. That's why they allowed the patient to be delivered vaginally to begin with, because it was not thought that this patient had a herpes infection. The babies may present with fever, lethargy, hepatosplenomegaly, seizures, and the skin lesions, but our goal is to make the diagnosis when the disease is still in the skin phase. We can prevent some of these serious complications, the lethargy, the seizures, the severe brain injury, if we can make the diagnosis while the patient only has skin lesions. The treatment is IV acyclovir given as soon as possible. So don't assume this is a staph infection. If we see wounds on the patient's exposed parts like the scalp or the shoulders, don't assume it's a staph infection. Don't assume it's trauma from a scalp lead. If you see a rash on a little baby that's vesicular especially, we should be immediately thinking about herpes simplex. And if we're not sure, treat with acyclovir and get the patient to a dermatologist if we're not sure. But there's little downside to treating with acyclovir, but there's a great downside if we misdiagnose herpes simplex and let it go for several days and it spreads to cause CNS disease, and that would be a serious mistake to be made. All right, so to summarize, mistakes do happen. We're never going to prevent all of them, but I hope that these cases give you some good teaching points and try to prevent some of these errors from happening again. And I look forward to talking with you and answering some questions in the near future. Thank you very much. I do hope that as a result of this talk, you will consider myocarditis. If you see a child with chest pain and fever, consider a cardiac arrhythmia in a patient with syncope who has an injury or has exercise-related syncope. Thank you.